of all the orthobiologics enthusiasts. I welcome you all. As you all are aware, this orthobiologics is a relatively new branch, or we can say sub specialty of orthopedics. And there are a lot of discussion wherever we attend orthopedic conferences about this orthobiologics. So the idea of having this conference or this webinar is to create awareness about this orthobiologics program, and hence in association with OrthoTV, we have started this program. The theme of this program is uniting diversity of orthobiologics and creating a evidence-based awareness or the program. See, I want to say to everybody that orthobiologics is not a shakalaka boom boom or no magic. Orthobiologics is an evidence-based program, and it has its own limitations, indications, and contraindications. We should use it in a proper indication so that we can get the desired result. And whenever we talk about orthobiologics, we talk about osteoarthritis knee, and that get mixed up. Orthobiologics and osteoarthritis knee get mixed up, and the key idea of having orthobiologics somehow get wean off, because osteoarthritis knee is not a and disease. We can control the disease, but we cannot cure the disease. So wherever we discuss orthobiologics in osteoarthritis knee, sometimes there are many disappointment or other things comes, even though orthobiologics doing extremely good for osteoarthritis knee as well. But the idea of having this pilot project or this webinar is using orthobiologics in those indications of orthopedics where we can put end of the disease, where orthobiologics can be a definitive modality of treatment. So considering this point, the theme of this first series is fracture non-union and malunion, because once we get these conditions, so other than going for bone grafting or any surgical intervention, we don't have anything minimal invasive procedure. So can this orthobiological treatment help us in coming out of this non-union and malunion status? So next 1 hour, we will learn about this. And on this note, I welcome my all audience. Let me take this opportunity to invite to introduce the vice chair of this entire web series, Dr. Daniel Moya, who is from Argentina, and my both moderators. First, Dr. Sanjiv. He's a professor at Lucknow, and KGMC Lucknow is a well-known medical institute and well-known face at Lucknow. Dr. Sanjeev, welcome you. And second moderator, Dr. Abhishek Arun Nerurkar. He's a consultant orthopedic surgeon at PD Hinduja Hospital, which is again a very famous hospital in Mumbai. So I welcome both of the moderators of this session, Dr. Sanjeev and Dr. Abhishek. And now I hand over the proceedings to the first moderator, Dr. Sanjiv Kumar, to please lead this webinar ahead. Thank you.
Good evening, everyone. And thank you, Dr. Jain, for having this series of webinar on this topic, which is not new to everyone, but the aspect you are telling to utilize this orthobiologics in end diseases where we can cure the disease by utilizing these orthobiologics. So this will be a great informative webinar for everyone. And this is my pleasure to introduce our first speaker, which is Dr. Nitesh Gahlot. He is additional professor at AIIMS Jodhpur, and he is a trained joint replacement and arthroscopy surgeon who has a special interest in shoulder and knee surgeries. To his credit, he has many reputed fellowships. To name a few, he is a trained fellow of British Indian Orthopaedic Surgeons in joint replacement and arthroscopy. He is IO ambassador to Korea for joint replacement. He is ISCSA International Fellow for Joint Replacement and Arthroscopy to Australia. He is a fellow for shoulder and elbow surgery from South Korea again. And he is also a fellow for Orthopedic Trauma Fellowship by AADO, that is Asian Association for Dynamic Osteosynthesis, Hong Kong. And he also received IOAWOC Sicard Fellowship, which is given by Indian Orthopedic Association. Apart from these fellowships, he has various publications to his credit in international and national journals, having citations more than 700 and H index 12 and I index 14. So he is a very trained and able surgeon and very good academician. I will be inviting him to talk on the topic that is orthobiologics in fracture, non-union and delayed union. So over to Dr. Nitesh Gahlot to present your talk.
Thank you, Dr. Sanjiv, for a nice introduction. I will now share my screen. Yeah, am I visible and audible?
Yes, very much. Please start, Dr. Nitesh.
Yeah, good evening, everyone. For all the audience who are interested in orthobiologics, in today's webinar, we'll be talking about what is the use of PRP in non-unions and delayed unions. Now, this is
Please
a
do,
topic that has
Dr.
been
Nitesh,
researched
Dr. Nitesh,
by
please do
many
full
studies
screen.
in the literature.
Full screen.
Okay. It's fine. Now it's fine.
Yeah, I think it's fine. Go ahead.
Yeah. Okay. So the non-union and delayed unions are a bigger problem with orthopedic surgeons. The definite answer is not there with us as of now. Multiple modalities are being used to treat the non-unions and delayed unions, and the PRP is now coming up in a big way in this. I will be just brushing upon what the literature says, what is the evidence we have as of now today, and what things you can do with the PRP according to the literature as of now. The non-unions, US FDA way back defined non-union as a fracture that has failed to heal within the first 9 months following the injury, or at least is not showing any signs of healing in the at least 3 consecutive months. But this is a very general definition, and we all know that it cannot be applied to all the bones and all types of cancellous and cortical bones. So there is currently no standardized system to define a non-union. It depends on the clinical opinion of a clinician that when he or she believes that the fracture has little or no potential to heal. 10 to 15% of the fracture patients, they go into impaired healing, which is a big number, which can ultimately lead to non-union, if not all. And the characteristics of an impaired healing, which you can identify, if the patient is having persistent pain even after 4 or 5 months of fracture. There's a poor bridging of the fracture site by the callus formation. And there is a persistent radiolucent line at the fracture, which can be visualized via X-ray. Multiple risk factors associated with it have been described multiple times in the literature: age, alcohol, smoking, deficiencies of multiple vitamins. All these are there. You can prevent. But once you have a non-union, why are we worried about that? Because it causes significant morbidity to the patient. It puts the lot of delayed healing. When that happens, patient undergo additional hospitalization, extensive surgical treatments, 2 to 3 average surgeries are to be done, a further 4 to 8 months to recover from. This additionally puts a lot of stress on the healthcare system also. So what is the treatment we have? The current gold standard we know is the autologous cancellous bone grafts. The bone grafts, they provide a fresh source of bone cells to help jumpstart the healing process. Disadvantage is that it has a limited supply. There is a donor side morbidity. The researchers are currently exploring alternative therapies because of these disadvantages. And the PRP has come in a big way up in addressing the non-union treatment. But why PRP was thought of? What is the advantage that it gives? The PRP has a role in regeneration. Multiple studies have shown its efficacy in osteoarthritis, rotator cuff repair, and bone regeneration. No. The rates of centrifugation definitely differ, ranging from 3,200 to 5,200. That is a lack of standardization. Among the literature, throughout the literature, the activator that is needed for the PRP, which is to be given before the PRP has become effective, also is different among all the studies. It ranges from thrombin, calcium chloride to calcium gluconate. The volume of PRP among the studies also differs significantly. It ranges from 2.5 ml to around 20 ml. The total dose given is in multiple studies given as a single dose. or multiple injection over the weeks. So there is a lot of difference in the studies that are reported. The methodology is very different. It's very difficult to make a generalization out of these studies. This is the basic idea of how the PRP is harvested, platelets separated, extraction, the activation, and then this activation is with the activating agent and the delivery is done at the non-union site. Now, what is the impact of PRP on bone regeneration? Most of the published studies, they have a basic problems. They fail to report very key aspect of their outcome, such as they don't report how much was the platelet concentration, they don't report the leukocyte components, and they don't report the activation modalities. Few of these studies have addressed that. So if you inject a medium quantity of platelets in the PRP, it leads to osteogenic differentiation of bone marrow stem cells and it improves in fracture healing. But if you inject a high quantity of PRP, it starts inhibiting the osteogenic differentiation and delays the callousity modeling. So you have to be very conscious. The leukocyte-rich PRP induces higher proliferation of bone marrow stem cells. This highlights that different concentrations and ultimately different levels of activation will affect your efficacy of the therapy. You have to be conscious what you are injecting. PRP can be used in isolation or in addition to other modalities. When used in isolation, has been found to be unsuccessful by a couple of studies. They used it in all the patients, and at 10 months, none of the patients united. They used calcium chloride as an activator, and around 5 ml was injected, or at least on 3 separate occasions. The PRP has successfully induced a union if bovine or autologous thrombin for activation was used. So this tells us that the activation using the calcium chloride alone, or if you are using a lower dose of PRP, can lead to an unsuccessful outcome if you are using a PRP. So you have to use either a thrombin as an activator, or you have to use a higher dose of PRP. The amount of which you are injecting, like in milliliters, that has to be higher, not the smaller amount. It has to be approximately more than 5 ml at least. Secondly, use of PRP as a hybrid treatment. Now, this is most commonly done. When PRP was combined with Eliquis autograft, it increases the healing potential. It has increased the healing potential in almost all the studies. Problem is, most of the studies are non-randomized. So you cannot tell whether the PRP is causing the union or it's because of the autograft. One RCT has been done where it was compared with the placebo, where autologous bone graft and internal fixation was done, and PRP group had a significantly higher healing rate. That means it is definitely beneficial. Case series have largely been positive, but then the drawback is because there is no control. One RCT compared PRP plus internal fixation versus PRP internal fixation alone, and the PRP had significantly increased rate of healing. Now, 2 case studies have compared PRP plus mesenchymal stem cells. Now, this is a very new concept. Both these studies have reported that the mesenchymal stem cells plus PRP is successful in patients who have failed when you have used the Eliquis bone graft for managing the non-unions. So this technique might be helpful in those resistant non-unions where even your Eliquis bone grafting has failed to achieve a union. You can inject the stem cells plus a PRP. This highlights how the PRP can help in improving the bone regeneration in very difficult cases. There are various other factors. The answers are pending, like activation agent is whether needed or not. So a few studies say that by Malhotra et al. That sufficient thrombin is produced by local trauma. You don't need to inject separately thrombin as an activator. Then timing of administration. You should inject the PRP within first 11 months, and then its effectiveness reduces. Fracture gap. The fracture gap has to be less. You cannot just inject PRP in gap non-union and expect it to unite. The fracture has to be stabilized and the gap has to be less for the PRP to be effective. One alternative treatment which has been compared with PRP is recombinant human bone morphogenic protein 7. This is a very strong activator and definitely it is superior to PRP. But then problem with this is it is very costly. One injection can cause around 1 to 2 lakh rupees. So it can be used in resistant cases, but it definitely cannot be used in every case scenario because it's very costly. So in all the studies, the PRP has demonstrated success either alone or or with additional bone graft to improve. However, like you can inject in the non-union site percutaneously using a needle. We recently published this in a delayed in a case series of a delayed union of diaphyseal fractures. We used leukocyte-rich PRP in those cases, and we achieved union in all the around 40 cases except one. So that was a very good outcome, and I will share a few cases with you. This is a case one. This is an open grade 2 Gustello-Anderson distal femur fracture on the left side. It had no distal neurovascular deficit. It was managed with plating as should be done, but as it was an open fracture, there was some callus formation over there, but still months passed, and the patient was having persistent pain, and the margins are probably going into a non-union. 6 months and 7 months follow-up, the complete union had been achieved on the lateral posterior cortex and on this cortex, and the patient was pain-free. And this is 9 and 10 months. The complete union was completed, and the patient was walking with full range of motion. Another case, this was regular sharp femur fracture with a butterfly fragment. Nailing was done, close nailing was done, but at 3 months, still the callus formation is not adequate. It is probably going to go into a delayed union, or probably because butterfly fragments are very prone to go into non-unions, and it might go into a non-union. So we injected 2 PRPs at 1 month interval, and that all these were injected percutaneously under Shyam guidance directly into the fracture hematoma or in the fracture area. And after that, at the 5th month, they got a good union. So in conclusion, the PRP is demonstrated success when it is used in isolation or in the dose range of 2.5 to 20 ml. But the important thing is non-union would have to be inherently stable. You cannot expect PRP to give you a union in a patient who has unstable bone fragments. You have to fix it stably. Bone gap should be less, and then you inject the PRP, then it's going to be effective. PRP would ideally should be administered within 11 months of injury or the initial surgery. And the common activator bovine thrombin may not be a necessity, but if you are using an activator, use thrombin rather than calcium chloride or anything else. Few future research, few questions are definitely there. Whether sufficient thrombin is produced for local whether you need an activator or not, you can directly inject PRP or not. And what is the most effective method of PRP preparation? And the administration, whether single or multiple injections are important. What is the rate of not standardized as of now? And they need to be systematically investigated and standardized. Thank you.
Okay, Dr. Nitesh, you have talked very well regarding use of orthobiologics for non-union. And I believe non-union are the cases where surgeon is always worried if he is not able to see the callus in fractures in due course of time. And then things start getting like problematic when patient asks you again and again why it's not uniting and what was wrong and how we can improve the outcome, right? So may I ask few questions to increase the discussion in this regard, right? So for what is the earliest time after fixation you believe that if these orthobiologics are given, they are given at right time? You should wait for non-union to be established, or when you are not able to see callus after maybe 6 weeks or 12 weeks time, and then you should intervene with these things.
Sorry. So a very valid question that you have, Dr. Sanjiv.
Right.
I personally believe if we intervene in the delayed union phase, that is approximately 3 to 4 months after the fracture, when you are not seeing adequate progression of the callus union or the fracture union. That is a much better time than using it in a frank non-union. Most of the studies have a frank non-union. Very old. So have already frank non-union and atrophy kind of non-union, or I think the literature of delayed union when there's still some vascularity left, bone fractures, and approximately for other bones also.
I agree with Dr. Nitesh. Actually, to establish a frank non-union, you require 9 months to wait, nine or so by the theoretical definition. And since this PRP or GFC injections are non-invasive, so you can give after 3 or 4 months also after taking a clinical decision that you are not getting adequate callus, because it is a minimal invasive procedure, very easy to do, OPD based procedure. So best time to intervene is at the time of 3 to 4 months when you are not getting adequate callus and you want to intervene. So absolutely I agree with Dr. Nitesh Gahlot about this. So
Right.
yeah, over to you, Dr. Sanjiv.
That's absolutely correct that we should not wait for non-union to establish. Rather, we can intervene early so that we can get better results. Right. So I just want to ask one thing that, like orthobiologics, from they're available, various type of orthobiologics are available in market. Like, so whether only a blood aspirate from iliac crest or a PRP or these commercially available preparations who prepare growth factors or sort of thing. So would you suggest that anything can be done, or you are talking about any specific thing?
Uh, so basically, blood we aspirate
Dr. Nitesh, I think
all
your
and
network
everything.
is poor.
What the people started. Yeah, I think, yeah.
Okay.
Can you hear me now? Yeah.
Yeah.
So when we bone marrow aspirate contains everything from stem cells, all the growth factors and everything. People started separating all these things. They separated stem cells, they separated growth factors, they separated platelets, and all those things. Now, the usage of different products in terms of bone union is not much different. But if you have a very specific function that is done there, where you cannot inject the whole blood because it clots there, you cannot inject blood everywhere. So then you can inject stem cells, then you can inject other growth factors, and that depends on your indication. But for as per the fractures are concerned, I think bone marrow aspirate has also been used in studies. Has also been used. I don't think I could not find any comparison of PRP and bone marrow aspirate is done. I'm not.
I
I
think
would be it would be
I
interesting
think
to know
Dr. Madhan
any difference or
Jeyaraman is
not.
also there in this group. Dr. Madhan Jeyaraman is a secretary for this web series. So Dr. Madhan, can you please unmute yourself and put a highlight on question raised by Dr. Sanjiv, that whether to use PRP or GFC or BMAC for non-union, or
Yes, sir.
you want to use some commercial kit. So Dr. Madan, he is a excellent orthobiologics and orthopedic surgeon practicing in Chennai and secretary for this webinar. So Dr. Madan, please answer this question.
There are certain things we have to maintain sterility. As of now, we have to proceed with SEDESCO approved kits for preparing PRP. Unless and until we have a biosafety cabinet and technical persons to prepare in a lab with the sterile conditions, if this is not possible, better to go ahead with SEDESCO or DCGA approved PRP kits to prepare PRP for any indication use, not alone knee osteoarthritis or fractures. For any indication, whatever we are doing, it's better to go ahead with approved kits.
Dr. Madan, I was just wondering if there is any difference between putting bone marrow aspirate or aspirate from iliac crest, and PRP or growth factor in these non-union cases.
Come again?
If you
What is
are,
your doubt, sir?
I'm asking, sometimes we insert this bone marrow aspirate from your iliac crest and put it on the non-union site for enhancing the bone healing. So if you have any experience of that thing, and if yes, then
Sir, bone marrow, yes. Bone marrow is practiced decades to decades earlier. From decades to decades earlier, we are following bone marrow aspirate directly into the site. But bone marrow aspirate concentrate will give you the concentrated MSCs at that point. That is the only step. Otherwise, bone marrow aspirate contains very less number of MSCs.
Okay, okay, okay. So one thing I just want to ask again, that as Dr. Jain told, that this can be done on a OPD basis, and infection is one of the reason of non-union in case, even in cases where the infection is not obvious. So are you going to rule out whether there is infection is a factor for non-union, or if you are okay with non-union, you can go ahead with this insertion?
Sir, actually your PRP or BMAC or SPF or any type of regenerative products, they have antibacterial peptides.
Mhm.
Basically, even you can do it as a OPD basis on a daycare basis. There is no problem unless and until you follow a standard protocol in giving proper strict aseptic precautions. If everything goes right, nothing is going to hamper, nothing is going to cause your infection there.
Mhm.
Just to take the entire audience to our first year PG days, when we used to take iliac bone graft and put it for non-union site. And what is iliac bone graft? That is nothing but bone scaffold soaked in bone marrow.
Right.
So we are doing orthobiological treatment from right from the first day of our PGs. The only thing is that now we are using in a concentrate way. Meanwhile, Dr. Daniel Moya has raised his hand. So Dr. Daniel Moya, please raise your query.
Thank you very much. Thank you, Dr. Nitesh, for your nice presentation. Going back to the indications, I think that in some way we face a dilemma here, because on one hand, we, of course, as orthopedic surgeons, want to prevent the patient from suffering a non-union. We know that the impact it has on patients is very big. Even the divorce rate and the alcoholism rate in patients with non-union is much higher than in the general population. But on the other hand, the use of these methods is not completely well established in our field, and many people has doubts about the use. So I think that even though using, for instance, PRP in a femur fracture after 3 months could be good for the patient, but it will arise many doubts in our colleagues. Perhaps they could say, okay, if you would have waited for this fracture, femur fracture after 3 months, could develop a healing of the focus after 2 months more. So I think that we have a dilemma here. We need to find proofs that will support the use of this method with um, methodological and scientific support. But on the other hand, we want to help our patients.
Uh,
Very.
Dr. Daniel, just to add a point to this, yes, you are right. After 3 months, if you intervene, there is always a point that if you wait for 2 more months, it might unite. But there are cases where it will not unite. So since
Yeah.
it is a OPD based procedure, and if you give 10 out
Mhm.
of 10 patient, you are not harming the patient. So out of 10, if two patients will go for non-union, establish frank non-union, and by giving this injection, if you can delay that or if you can undo that part, then there is no harm. And I'm sure that
Yeah.
next series of webinar where you will talk about shock waves, so we will have a better different way of looking the non-unions. So I take this opportunity to invite the entire audience for the next session of webinar for this coming out 20th of March. So, if my fellow colleagues, Dr. Abhishek and Dr. Nitesh allows, shall we start the next talk because it's already 8:30. So, I hand over the further discussion to Dr. Abhishek, who is the moderator for the next talk. So, Dr. Abhishek, over to you.
Hi, good evening, all. Let me first give you introduction of Dr. Ashim Gupta. Dr. Ashim is a board certified diplomat and fellow of American Board of Regenerative Medicine. He is the founder and chief executive officer of Regenerative Orthopaedics and Future Biologics. He also serves as professor and chief science officer for South Texas Orthopedic Research Institute. So he's completed his MS and PhD from the School of Medicine, Southern Illinois University, and he has pursued his MBA from the School of Business, Southern Illinois University. He serves as a visiting consultant for several clinics and medical scientific advisory board of several medical device and biotechnologies company, both in US and in India, and is a member or guest faculty of numerous societies, serves as an associate editor, guest editor, editorial board member, and reviewer for several international peer-reviewed journals. With this small introduction, I invite him to talk about his research-oriented goals in biologics, in orthobiologics, in non-union and delayed union. Dr. Gupta, all over to you.
Thank you, Dr. Abhishek, for the kind introduction. I'll go ahead and share my screen. Am I audible clearly, and can you see my full screen?
Yes, we can see. Please go ahead.
Minimize this here. All right. So I'll talk more on the evidences we have on non-unions, and I'll skip the introduction since Dr. Nitesh already covered most of it on what non-unions are. So I'm going to talk more about the regenerative medicine treatments. So when we talk about the regenerative medicine treatments, we have two sources: the autologous, that could be peripheral blood, the bone marrow, the adipose, or allogenic, which could be allogenic bone marrow or adipose tissue derived cells, or the tissues, placental tissues, and the umbilical cord. So first part, I'm going to talk more on the autologous sources. So when we talk about the autologous peripheral blood derived orthobiologics, the first thing that comes to our mind is PRP. And Dr. Nitesh did a great job in presenting us with a lot of evidence surrounding PRP. So in addition to PRP, we have platelet lysate, which is again derived from PRP and formulated via double freeze-thaw cycle. We have autologous condition serum, which is formulated by incubating the whole blood with glass beads. Then we have others like plasma rich in growth factors. We have growth factor concentrate, autologous protein solution. So I will, for the time's sake, I'll skip all the definitions, but we summarized all of these in an editorial. So you all can always go back and refer to this. So first I'm going to start with the PRP, little bit of our work led by Dr. Karun himself. And for this particular article, the growth factor rich concentrate is nothing but a leukocyte rich PRP. And Dr. Nitesh already went over a lot of literature for PRP, so I'll go quickly on it. So in this specific study, we had 17 patients. Inclusion included radiological diagnosis of long bone marrow non-union fracture. Patients who gave informed consent and were over 18 years of age were included. Anybody younger than 18 years have a platelet count of less than 150,000 per microliter, were taking NSAIDs or other medications influencing platelet count or aggregation, have infections, pseudoarthrosis, and others listed here were excluded. All these participants received 3 doses of 5 ml this growth factor rich concentrate, which was administered 2 weeks apart. And they were assessed at baseline as well as 1, 3, and 6 months post follow-up. And these are the demographics. So we have about 53% males and about 47% females. We have majority patients have no comorbidities, but we did have some patients who have diabetes, hypertension, or one patient had both diabetes and hypertension. This is their injury characteristics. And we had 14 patients who had great outcomes, 3 patients who had poor outcomes. And when we looked into association between comorbidities and treatment outcomes, there was a significant association. And the 3 patients who actually had poor outcomes, they underwent bone grafting and secondary plating at the end of 6 months follow-up. So as I said, it's nothing but a PRP created using double spin method. And I always suggest at all my lectures that every time you prepare PRP, you have to categorize it, you have to quantify it. So since we were calling it growth factor rich concentrate, so we had to quantify what kind of growth factors are present. We did ELISA, and some of them are listed in this cartoon. And we also characterized all these parameters: what's the platelet count, RBCs, total leukocytes, and we did not use any external activator. So out of a lot of patients, just some examples. So you can see this is a intermedullary nailing of tibia. Patient had non-union fracture, and then over the 6-month follow-up, you can see good callus formation. Another patient with right forearm, you can see fracture at the middle 1/3 of the ulna, and at the end of 6 months, you can see formation of nice callus. We also looked into the mean Warden score, and at the end of 3 and 6 months follow-up, the Warden score was statistically significant compared to the baseline score, showing significant amount of callus formation. So just to summarize, I also wanted to look if there is any recent level 1 evidence. Came across this study from Bone Reports, and this review had 20 studies included in the review, with about 490 patients which are affected by non-union and over 250 patients affected by delayed union. The mean follow-up was about 16 months for non-union patients and about 8 months for delayed union. And the results showed that orthobiologics, especially PRP, tended to yield better outcomes compared to surgical procedures done without any of these bioactive factors. So we know that all these orthobiologics, especially PRP, it has potential to improve union rates, reduce healing times, and enhance functional outcomes in patients with non-union. So going forward, we wanted to also look if there is evidence for other autologous peripheral blood-derived orthobiologics. So we looked into the platelet lysate, came across this case study where the patient received an internal nickel-clad breakage at 9 months post-surgery, but did not want it to go for the revision surgery. So in this patient, they injected platelet lysate 3 times at a week difference, and they found improved clinical evidence at 4 and 6 months after the injection. He had good bony union at 8 months post-injection, and he did not feel any discomfort post-injection, no complications such as infections, refracture, or anything. So this is the preoperative radiographs for the patient. And this is how the patient progressed at 4, 6, 7 months. And at the image D at the end, you can see the nickel-clad breakage. So they went ahead, injected, and you can see in figure A, the needle with the injection, and they followed the patient. And then at 6 months follow-up, you can see nice callus formation. And this is how the appearance of the leg was after they removed the plate at 12 months. And you can see that in figure C. Next, we wanted to look into if there is any evidence for autologous condition serum. Came across this article, and this study examined the efficacy of ACS in a non-union in patients who failed open reduction internal fixation. Had 11 patients in this study with at least 9 months post-ORIF or had total hip replacement. These patients received once to 3 times monthly. So 7 patients got ACS injection 3 times, 3 patients got it twice, and 1 patient who underwent hip replacement as well only got it once. So 10 out of those 11 patients achieved union at the last follow-up visit, showing effectiveness of ACS in non-union cases. And this is one of the case examples of a 50-year-old female who had a non-union tibial fracture. And you can see even in the image C that even at 9 months, it did not heal after the revisional intermedullary nailing. So 3 months after that 3 injection, ACS led to good union as visible in the figure D. Another case from the same study of a 30-year-old male who had a non-union femur fracture. And again, you can see after 1 year, after the 3rd injection, he showed complete healing of the bone defect. So I also looked into the gold-induced cytokine, growth factor concentrate, plasma-rich in growth factors, autologous protein solution, and hyperacute serum, and did not find any studies which involved any of these biologics for the management of non-union or delayed union fractures. So we were just discussing about utility of bone marrow aspirate or bone marrow concentrate. So came across this general review, and this review had 25 studies, and it showed successful treatment in both aseptic non-union, though the slighter better rates were observed in septic non-unions. 18 out of 24 studies showed union rates of more than 80%, and one study reports successful treatment of septic non-union with BMAC and no antibiotics. So this literature, if we look into it, it shows that both bone marrow aspirate as well as the bone marrow aspirate concentrate, it's extremely heterogeneous in terms of patient population and concomitant treatment modalities. So though the results are promising, we need more studies. How about the data pertaining to the cultured bone marrow mononuclear cells? So came across this study where they use these culture cells loaded onto an allogenic decellularized lyophilized spongy bone cubes. 10 patients were randomized into the tissue engineered product, and then 10 were just treated with the standard of care. So the degree of consolidation estimated by measuring the Hounsfield units on CT showed no difference whether you do a tissue engineered product or you follow the standard of care. So what's the utility of that? It shows tissue engineered product as an alternative when you cannot do an autograft or if it's contraindicated. So this is just case of a 36-year-old male, and you can see the non-union site and how they implanted the tissue engineered product and how the bone defect looks like after they implanted this tissue engineered product into it. And on the right, you can see at 12 months follow-up, complete consolidation was observed. Next, moving on to the adipose tissue. So we know adipose have multiple tissue types. So we wanted to start with the microfragmented adipose tissue, the MFAT. Could not identify any studies using MFAT. I looked into the stromal vascular fraction, came across this case study, and this presented a case of conservative treatment of delayed union of a radial bone fracture using local SVF injections. Excuse me. So here they actually used SVF with PRP, and they found progress in both clinical as well as radiological dynamics, and led to like complete healing within 7 months. So this is like the X-ray picture. Like first they use like an external fixator. 2 months they removed the external fixator and observed delayed union. Afterwards, they used an LCP to fix it. And at 5 months, since they again did not see any callus formation, they went ahead and administered this combination of SVF with PRP. And 6 months after injury, we can see formation of the callus. Next type of adipose tissue-derived product is the adipose-derived stem cells. So again, came across this review. So I just try to focus on the most recent evidence which is available, starting with level 1. If I couldn't find level 1, went to level 2, couldn't find level 2, then stayed with whatever review or case report or case series is available. So in case of ADSCs, this article has only 3 articles with 12 cases analyzed. It's a very low level of evidence for a review because the 3 articles, 2 were just case series and 1 is just a single case report. And again, based on these, we can say it represents a promising alternative for enhancement of non-union and bone defects. But again, we need like higher level evidence. So now switching gears, we all talk about autologous, but there are a lot of centers who are using allogenic sources. So I also wanted to look if there is any literature available for the allogenic sources. So first I looked into umbilical cord or umbilical cord derived mesenchymal stem cells, came across this original article, and they did non-union fractures with critical sized bone defects. And they had 7 patients, 3 males, 4 females into the study. And they all showed increase in the lower extremity functional scale during the end of the follow-up period, showing improvement in the function. And the follow-up actually ranged from 12 to 36 months. So as an example, I just picked one of the random cases with a 15-month follow-up for a patient with femur issues, and you can see like a nice healing or the formation of callus at the 15 months follow-up in this patient. I also looked into studies involving amniotic tissues or exosomes, and I could not find any literature for the same. And then I know a lot of people like to use prolotherapy and ozone, so I put them as miscellaneous, and again wanted to see if there is any literature involving prolotherapy and ozone, and I could not find any published studies indexed on PubMed. So the future therapies, what even Dr. Nitesh discussed and we were discussing. So, and I also discussed one case of SVF with PRP. So now people are trying what we call biocomposites or bioregenerative scaffolds, where more than one biologics is used with or without presence of a scaffold. So came across this case study where they used a bioregenerative scaffold derived from bone marrow aspirate, cancellous bone autograft, PRP, and autologous fibrin. And all non-unions, they exhibited healing with sufficient callus formation, confirmed radiologically, and after 6 months, all patients resumed full weight bearing. So what's going on in the literature? Are there any more studies? So I only looked into clinicaltrials.gov. There could be more studies at Clinical Trials Registry of India or Chinese Clinical Trial Register. So I found only one study involving bone marrow derived MSCs for treatment of non-union fractures. Also came across one study involving PRP and one study involving SVF. While doing so, I found another study which involves all like allogenic bone marrow, allogenic adipose, and allogenic umbilical cord. Study being done in Indonesia to see which of these cell type is good for bone defects or non-union fractures. Also came across another study which involves use of human amniotic epithelial cells. So maybe when they are done and publish their results, we'll have more insight into other cell types and their role into the non-union. So several limitations of these published studies. We definitely lack high level of evidence. I could not come across even like a level 2 study. There is variability in formulation protocols, definitely applies to bone marrow, SVF, or PRP. Lack of characterization of these formulations. All these studies have very small cohort size, and there is very short to mid-term follow-up. So if I have to conclude, yes, these orthobiologics have potential to augment healing of non-union and delayed union fractures, but we want more studies to establish long-term efficacy and also determine which one of these is an optimal orthobiologics, meaning we need more randomized controlled trials comparing one orthobiologic to the other. And people always ask me like, hey, where to publish regenerative medicine articles? So I do edit for a lot of journals, and you all are more than welcome to submit here. If you have any questions, need help, you can always email me. And with Dr. Karun, we'll be organizing the second Delhi Orthobiologics course. So I invite all of you to come and be a part of this wonderful event with us. Thank you.
Thank you, Dr. Ashim Gupta. That was quite an elaborate review of the current, literature available. I wanted to ask you one thing, and all the panelists, of course. What is the difference between, so we have been using this orthobiologics for the knee arthritis. So basically, what is the difference between the orthobiologics that we use for knee arthritis vis-a-vis the orthobiologics that are used in case of non-unions and delayed unions?
So these are pretty much the same orthobiologics that you are using for knee. And I believe those same principles apply here. So if I have to start with like what Dr. Nitesh was saying, that we can't repeat or we can't reproduce is lack of standardization. So it's very essential whether you make PRP or BMAC or SVF, you need to like characterize the formulation. So anybody else in the world can like repeat and reproduce those results. So they know what you injected. Just saying I did BMAC or I started with 20 ml blood and I made 5 ml PRP does not suffice. people need more information than that, because everybody is like, for example, baseline platelet levels vary. They may have different comorbidities. So people want to see that entire history, proper characterization of whatever formulation is used. So in nutshell, same principles for NEOA applies here too.
But currently, literature based, do you have any specific things that you look for your PRP or a GFC or whatever orthobiologic that you are using, or it's still under research?
So if we
Abhishek, I
talk
would
like
like to answer this question.
Yes, yes.
PRP, GFC, everything comes under whatever Asim told. It is ABPO, autologous blood-derived peripheral blood-derived orthobiologics.
Sorry to disturb, Dr. Madhan. Can you switch on your camera as well? It will be more interactive.
Okay, just a minute. Yeah. So, PRP, GFC, everything is coming under autologous peripheral blood-derived orthobiologics. The ultimate product which is going to deliver at the site of action is growth factors. So everyone is going to be the same with different names and entities, and there are different kits available for preparing each and every entity. The rest, the action, the potential mechanism of action is going to be the growth factors, which is going to create your neoangiogenesis at any site of action once it gets released. Either it is a fracture or a cartilage or any tissue, tendon or bone, everywhere. Musculotendinous unit, osteochondral junction, everywhere it will create only neoangiogenesis, followed by your resident stem cell activation in that particular locality. Either it is a bone tissue, cartilage, anything. So this is the main principle which is going to act, but not the product. The product's names are different, but the mechanism of action is going to be the same.
I
Right.
agree.
So
So there
by
is a question by Professor Dr. Vikas Trivedi, and his question is, what is your opinion about OCNext GFC kit, that is commercial driven kit on long bone non-union and delayed union? And if yes, then what is your opinion? So
Yes.
Dr. Madan was answering, see, suppose we are doing a intertrochanteric fracture and PFN is required. So you can use any company PFN right from the local manufacturer or a imported AO PFN plate or any Merrill or Medtronics, any company. The principle of nail remains the same. So any kit you use, whether it is a commercially available kit or you make by yourself, the principle stays same, that you should have growth factors in your serum. That the precisely Dr. Madan also told. So if we are using the principles of orthobiological treatment, then we are whatever commercially available kit you are using it, that is fine. And his next question is, what is the treatment protocol, whether 3 injection and what difference? So Dr. Madan or Dr. Ashim, you want to take this question?
I take so. There is nothing called consensus are there for like 3 injections, how many days in between interval difference. There is no consensus. It's up to you and your institute how you want to treat a patient, whether you are taking up for a study or personalized treatments, depending upon today's lecture is about delayed union and non-union. Just to see the speck of callus in first injection. If you are seeing the speck of callus, wait for 3 weeks, give the second dose. If more specks of callus are forming, then go ahead with third injection and see for the union of bone. It's not about number of injections. Whether your PRP or growth factor concentrate or hyperacute serum, anything, just look for your callus formation. Then you can decide how many injections you want to keep or not. Certain patients will need only one injection if it is a fresh non-union. If it is a delayed union, it may get 2 to 3 injection. If it is a non-union, then yes, you have to go and deliver it like peppering technique. Go and hit the bone, edges of the bone, both the sides, create a paprika sign, that is called peppering technique, and instill your injection. We are treating the fractures in a biomolecular way, not a mechanical alignment or anything. So better give a brace or a support while you are giving that injection. Anyway, it won't stay in particular place. It will dissipate into the forum, but it will activate your resident stem cells. That is the most important thing which we need to target. And one more thing, if you want to use a scaffold gel kind of substance, you can go ahead with injecting IPRF, that is called injectable platelet rich fibrin. That also will give you a scaffold kind of material and jellified form of your autologous peripheral blood derived orthobiologic that will help you in getting the union faster.
I would like to add a point to this, but Dr. Madhan has very nicely submitted. And the basic idea is you have always to remember that your fracture has to be stabilized. It should not be a mobile fracture. If your non-union is happening because of the gap, if you have not dynamized the nail, first dynamize the nail, then the fracture gap should reduce. All those things have to be done first. Then your orthobiologics, whatever you want to use, can work. Now, orthobiologics can be used in both the ways. Percutaneously injection can be given at the fracture site, or people have also done open reduction internal fixation and applied on the fracture surfaces, both the PRPs and all the GFCs and everything. So all those studies are there. We don't know which one is going to be helpful. You definitely, if you want to go for a percutaneous way, OPD based procedure, then you can just do an injection. Shyam based injection we did in a study. If you are going in for a surgery, you have decided for operating and reducing that gap and along with other things, then you can definitely put it at the local site while doing the open procedure.
More point I would like to add. Already in 2021, I guess, we have published a paper on PRP in delayed union of fractures, where we have not characterized PRP. But now recently in 2024, we have published growth factor rich concentrate. It is not GFC, growth factor rich concentrate in non-union of fractures. Along with Dr. Ashim, Gupta and Karun, we have done one study and we have published in IJO where we characterized the platelets, we quantified the growth factors. We want to see how much growth factor is there in that particular level of solution, what we have prepared. We have quantified and characterized and we have given. The data is given in the supplementary file of IJO. Everyone can cross-check and you can prepare accordingly.
Dr. Abhishek,
Yeah.
over to you.
Yeah. So one more question I wanted to ask you is that, in PRP, basically we are dependent on the inflammatory mediators that is we have learned. Whereas GFCs, most of the kits, they give you that activated, they're already activated in the test and in the tube, before injecting. So does this make any difference, or it doesn't make any difference in terms of the results of these two particular preparations?
I think Dr. Gupta will be
technically,
an
it
excellent
should
person
not.
to answer this question. He's our regenerative scientist.
So technically, it should not. So see, the difference is when you inject, say, PRP in the body, the collagen inside is going to activate it. And here you are using an external activator. So you are just forcing the platelets to release all the growth factors. So even if you use an external activator, does not mean they're just going to secrete the anti-inflammatory cytokines. It's also going to secrete pro-inflammatory cytokines, because the whole cascade from pro-inflammation to anti-inflammation to tissue healing has to happen. So again, it's going to be a cocktail of all. But when we talk about like any clinical studies, to date, we do not have any studies which compare the GFC kit versus PRP head on for any indication that I know of. I do know that there was a study published by Dr. Sandeep Patel's group where they compared activated PRP versus regular
Non-activated.
PRP, and clinically up to a
No
year, they did
difference.
not see any differences. So he reported that whether you use an activated PRP or a non-activated, outcomes are going to be the same. So if we apply that same principle to GFC and PRP, from that, technically, we should expect the same outcomes. Unless
One
people
more.
can show that a good PRP versus GFC, like GFC has like higher growth factor content, and then how much, and then that gives us like a better outcome. Maybe that will be an answer. But again, then we need to characterize it first to know what is
Yes.
that growth factor content and what is the optimal growth factor content to attain that.
Here, one small thing. If such doubts are there, we can do a small study and see. Once you prepare PRP, subject it for growth factor assay analysis by ELISA. After preparing GFC from GFC kit, just subject that for seeing a ELISA of 5 growth factors. Just compare both. When there is no difference, it is not going to hamper any of your clinical and functional outcome.
Yeah, that is an excellent input, Dr. Madhan. So whatever you are injecting, just quantify it. So that is a way to go ahead about any of the kit which you are using it, whatever you are injecting, just quantify it. So Dr.
Days
Abhishek,
are gone. Everyone used to say, I have given PRP, excellent results. No, now things have come into play, like which PRP you have given, leukocyte rich or poor, or injectable PRF or GFC, what you have given, how many platelets were there, how many millions or billions of platelets were there. And third one is growth factors. How many growth factors have we quantified? Which growth factor is contributing for callus formation? All these things play a role. And one more thing, for soft tissues, it is better to go ahead with 3 to 5 times more platelets. But for hard tissues like bone, it is expected to be 10 power 7 to 10 power 8 times the baseline. So that many number of platelets are needed to induce your callus.
yeah, so I agree with Dr. Madhan. See, whatever you are doing it nowadays, now the blanket statement of that I have given PRP or I have given GFC is no more acceptable. For again, being a ortho surgeons, I always compare with the normal procedure that whatever plate you are putting, whatever nail you are putting, and when you put it in a conference, it will be scrutinized. It will be scrutinized by the mechanism of action, by the reduction and everything. Similarly, whatever injection you are giving, it will be scrutinized now, because it is a all time when you used to say that I have given a PRP and that's it, over and out. No, now everything, quality, quantity should be quantified so that we can create a evidence which is accepted by the world. Because if we just give a blanket statement, then the evidence cannot be created. Level 1 studies are pending, so many studies. So now the idea of this entire biological webinar is to create awareness about this orthobiological treatments in various indications other than osteoarthritis knee. So over to you, Dr. Abhishek.
Yeah, very aptly put. Any other questions that we have?
Yeah, Dr.
Abhishek,
Sanjiv has.
yeah, yeah.
Yes,
I'm
please,
just
please.
asking to all the expert. I mean, when patient comes to you and asks for some intervention for a delayed or non-union, so how you individually as a surgeon are confident, rather what you are going to tell your patient, how much chances are there that fracture is going to unite? Your individual experience. A patient comes to you, sir, there is non-union, you say you are going to put some sort of
So, Dr.
orthobiologics,
Nitesh, you want to answer?
because you need to give some confidence to your patient. No, he rely totally on you, sir.
I
Wait for some
usually intervene at the delayed
Nitesh, are you
union
there?
phase
Or
now.
Dr. Madan? Dr.
Can you hear me?
Nitesh is
He
there.
is answering.
So his question is how you counsel the patient about this injection and how you give confidence to the patient. So he's talking about the counseling about this orthobiological treatment in non-union.
Yeah. So the basic idea of telling the patient is that, and basic idea behind orthobiologics is it's a very cost-effective procedure. Secondly, disadvantages are very less, next to none actually. No allergic reactions, all those things are not there. It's an autologous thing. It is going to either benefit the patient or it's not going to do anything. It's not going to be a disadvantage to the patient. So instead of going for a surgery directly or waiting for 3 more months to frank non-union to develop or a union to happen in delayed cases, I would like to intervene in between so that it might help and again avoid a future surgery probably. That is how I counsel the patient actually.
Okay, great.
First thing, you have to talk about the smoking alcohol status, diabetic status, rheumatoid arthritis, all these things, steroid usage status, everything you have to check before administering any sort of treatment for delayed and non-union. This is my baseline. Then, once the patient crosses 12th week of post-surgical or non-surgical treatment, if the fracture is not showing any signs of union, I'll directly suggest there are certain options called minimal invasive procedures we can try. If the patient accepts, then I'll take a proper consent to proceed for the same. Either it can be a PRP or GFC or IPRF or BMAC, SBF, anything. If there is an option of dynamization to be done before giving PRP or after giving PRP, I never did any dynamization. I have directly injected at the site of action. So it has thrown some callus at the site of a delayed and non-union of fracture. I was happy and patient was also happy without doing any secondary surgical procedure. If I want to wait till the full-blown non-union to develop, I am creating a big morbidity and economical burden to the patient for spending more and more in getting treatment cost. So in this way, this orthobiologics act as a minimal invasive procedure in intervening the fracture. It helps in union. So if the patient is getting full functional outcome, then we can go ahead, but we cannot stratify any consensus for the same
We
because
have, yeah, Madhan, please continue.
these are all personalized treatment. It depends on person to person, depends upon the alcohol, smoking status, all steroid usage status, and diabetes status, everything. So we have to individualize it and personalize it once we offer the treatment. Only
Uh,
cafeteria approach.
Dr.
yeah,
Daniel?
so we have Dr. Daniel Moya also along with us, orthobiologic and orthopedic surgeon from Argentina. So, Dr. Daniel, what is your take on this? Can we have your expert opinion regarding this? Shockwave therapy we will have in next session, but about this orthobiological management of non-union.
Well,
Dr.
in
Daniel?
fact, yes, I can hear you. Yes. In fact, I agree that we must not only think in the fracture or about the procedure we will perform, we must consider the terrain in which we will use the regenerative medicine. Patients could have general diseases that would go against our results. Besides, the focus is stable. Besides, the good result or good options with the regenerative medicine. So it has been developed, and we could even invite in the future doctors working on this, that they have a profile that they study about the patient before deciding using a regenerative procedure. Because of course, a patient with hormonal problems, with diabetes, or some general diseases that would contraindicate, or even not contraindicate, but give us a very low chance of success. So in that way, I think that is very important. Second, to have a focus that is stable. The mechanics are more important for fracture sometimes than the biology. A bad mechanical atmosphere in the area will make the the stem cells to transform in fibroblasts and not osteoblasts, because fibroblasts are more prepared to deal with changing of pressures in the area. Osteoblasts need a very stable atmosphere related to the pressure. So I think that studying the patient, studying the fracture, the focus to have a stable fracture, and then the last decision is which procedure you will use related to ortho regenerative medicine.
Nicely
Yeah.
explained, sir.
Thank you, Dr. Daniel, for your
Thank you.
input. So, Dr. Abhishek, over to you again.
So I have one question for everybody, if I can interrupt.
Yeah,
Yeah,
So
Dr. Ashim.
I know a lot of you are doing like non-union fractures. So how do you decide which orthobiologic to use? PRP, BMAC, or SVF? How do you decide when to use and what to use?
I think, in my opinion, it depends on your personal, what you say, expertise. Like in orthopedics, if we are using a knee replacement, if I'm using Smith and Nephew and I'm trained with Smith and Nephew, so I continue to use Smith and Nephew because I'm getting good results. So that depends that whether the surgeon is getting good results by using PRP alone or by GFC or by any other formulation of the serum products, or they are using BMAC or fat cell derivatives or the exosomes. Like Dr. Ashim, you must be aware that we listened to Dr. Sandeep Patel, the PGI team, they are using a high concentrated PRP for most of the procedures and they are happy with the results. So they are not using the additional stuff. So that depends whether the surgeon is liking which kind of product. So I think my take is this, and rest Dr. Daniel and Dr. Madan can answer on this, and Dr. Nitesh is there.
My suggestion is, if it is a delayed union, fresh delayed union, go ahead with ABPOs. That is autologous peripheral blood derived orthobiologics. It can be PRP, GFC, IPRF, hyperacute serum, APS, ACP. So many are there. 10, 20, 10 to 15 are there. We can go ahead with anything. But if there is a non-union, established non-union, better to go and do a peppering technique of either IPRF or any form of cell therapy, because non-union, the definition of non-union has been changed over years. It is not the consecutive 3 months progress of fracture union. It is the deficiency of MSCs at the site of fracture. It is the deficiency of MSCs at the site of fracture leads to a complete established non-union. So this is what a molecular definition of non-union now, as of now. Maybe it is not consensus. It is just a personal opinion of few doctors. It has been published here and there. So I love this definition. So when you supplement it with cell therapy, which actually have cells, because the non-union is defined as depletion of MSCs at the site. If you add on cells to that, it will release your cytokines and it will form, it will release your growth factors and it will throw you some osteoblast and it will form a callus. So when there is an established non-union, which is of not more than bigger in size, just go ahead with cell therapy. If not, go with acellular products. Over to
Dr. Daniel,
Ashim or Daniel, sir.
Dr. Daniel, so what is your take about this acellular
Yes.
therapy, cellular therapy? How you choose between this?
Well, I am here to learn what to choose because my experience is limited to shock waves. I do not have experience on PRP, so I am here learning, and we'll
Interesting.
try to show you my experience on shockwaves. And there are even some papers that they combine shockwaves and PRP, and perhaps that could be an option. We need more proofs, we need more evidence, but there is not a contraindication about using both methods together.
So I take this opportunity to invite everybody who's listening to seminar that 20th of March, after a month, we will have role of shockwave therapies in orthopedics, and Dr. Daniel Moya will be our first keynote speaker on this, and he has agreed and given this kind concern that because shockwave therapy is very new in India for me and I think most of our colleagues, so he will give a good insight about it. So meanwhile, we'll go back to the main question, which cellular therapy or acellular therapy. So Dr. Nitesh, any protocol at your AIIMS Institute?
So basic idea is PRP is prepared in-house in our Department of Transfusion Medicine, so that's free. So any other thing that I'm going to use is going to cost the patient. I have asked about stem cells also. I've counseled patient about stem cells also, that costs around 1.5 lakhs or something in that range, because I do cartilage procedures also. So for that also, stem cells, we have companies in contact. So PRP is actually in-house and cheaper. So it's a go-to option for all those patients.
Totally agree.
If you are aiming at osteogenesis, please go ahead with bone marrow aspirate concentrate, which has bone marrow stem cells, which is more towards osteogenesis. But if you are aiming at cartilage growth or cartilage specs regeneration or anything, go ahead with adipose tissue biologics, which is more towards chondrogenesis. But all stem cells will have some amount of osteogenesis as well. That's why it is called a stem cell. Any stem cell, it should be able to differentiate into cartilage, fat, and bone. So if you are aiming at more of osteogenesis, go ahead with bone marrow, aspirate concentrate. If you are expecting a chondrogenesis, go ahead with adipose tissue biologic. But all cells can be used for every osteogenesis, chondrogenesis, or adipogenesis.
Dr. Madan, I think we'll stay to the non-union and malunion, not the chondrogenesis, because
Then
this
malunion, non-union, better is bone marrow adipose, bone
yeah,
marrow derived
because
stem cells.
this is a direct webinar. We will have subsequent seminars on this chondrogenesis and everything. But the entire idea of this webinar is one day, one topic. So today's theme is non-union and delayed union. So, Dr. Abhishek, anything else you want to add up or?
Uh, no, I don't see any other questions. Although I had one thing in mind. I mean,
Yeah,
just to
please ask.
what you are asking about, what you are saying previously. Whatever is functioning in your hands, you can use it. But most of us and most of the viewers definitely wouldn't have used any kind of a modality for, by the time they're viewing this, for any non-union or delayed union kind of a scenarios, because this is not very common in our scenario to use this kind of a therapy for a non-union delayed union. So what is the advice to such people who have not used and how they can proceed?
See, the first and foremost is, as a surgeon, we need to understand the science. We need to be convinced with the science, and then we need to take, patient in confidence. This is, as Dr. Nitesh told, it is a OPD based procedure. It does not carry any side effect profile. It is a very safe procedure and very minimal cost involvement. So by doing this, one thing is very sure, that you are not doing any harm to the patient. So either you can have a
I
good
was asking
outcome.
about the different options that are available, how to choose, because once you start using them, you are more conversant. But when
Yeah,
you are
so
using any,
this is
then
this is precisely the point. The first line which I told, as a surgeon, we need to choose, we need to understand the science first. See, when we decide, how you decide between DHS and PFN. My question to you as an orthopedic surgeon, you have particular indication of using particular DHS or particular PFN, and if you are using PFN, then whether you're using two screws or your helical screw which you are using, or you are using in osteoporosis helical screw with the this thing cement you are using. Similarly, first sit quietly. If you are very new or beginner, my advice is, do not listen to the commercial kits, because they are here to sell the product. Just sit and read about the science. You have good amount of data available now on PubMed. You have a good research papers. Read about those research papers. Understand the science. You have meta-analysis is there, systematic reviews are there. Understand the science and then start using it. So for anybody who's starting it, start reading it and then doing it. Madan, anything you want to put it?
One more.
Yeah, please.
Any surgeon who is using PRP or GFC, whatever regenerative modality, please check to that if a patient has any active cancer, ongoing treatment on cancer, whether it's a surgical or medical or radiotherapy or any form of benign disease in any part of the body, better not to give any regenerative modality, even if it is a local injection, because one of our orthopedic surgeon has given injections in form of a local injection, but the benign disease has got into florid disease, so better avoid it. If any signs of cancer or cancer related precancerous lesions, better avoid regenerative modality. Go ahead with only the traditional way of treating a disease. Otherwise, other indications can be taken up. Only absolute contraindication is ongoing cancer, or cancer with radiotherapy, or pre-malignant disease. As such, regenerative products never cause cancer. Cancer stem cells are different. This PRP or BMAC or SPF all are anti-tumorigenic, but in ongoing cancer, it will definitely aggravate the cancer, because these are all the regenerative material which give growth factors to culture or proliferate the cells. So better any signs of cancer or benign precancerous lesion, better to avoid it.
Dr. Abhishek, at the point you asked, just would like
yeah,
to add, if anyone is in the peripheral center, or who is in a small center, everyone is treating trauma patients like that, and non-unions comes to everyone equally. So the cheapest option and the very easy to go option is the bone marrow aspirate. You don't need any centrifugal machine. You don't need anything. You can aspirate from the iliac crest and then inject it. That is a very go-to option. and can be used by very easily. Centrifugation machine is the next option if someone can procure it from somewhere. I think comes from 10 to 30,000 in between. Some company guy came and told me. If that is there, then PRP can be injected. If someone has access to that blood bank or some there. And because non-unions we are talking about, leukocyte-rich PRP is easier to make as compared to leukocyte-poor PRP, and LRPRP has benefits in shown benefits in fracture non-unions. So that is easier way to go. All other options, and these including these options, are available commercially also, but they come at a cost definitely. So if the patient is, those can be done. If you are asking that question, I hope if I've answered that question partially.
So I think it was a great discussion. It was the first session of Orthobiologics meet, and it was a nice discussion, a nice thing to ponder upon and think upon, because we've not been thinking about all these things in the past. It gives us a different angle to treat our non-unions and delayed unions. And I would like to thank all the faculty here, Dr. Daniel Moya, Dr. Gupta, Dr. Madhan, Dr. Karun Jain, who has been a organizer for this, Dr. Dharshan, Sonawane, Dr. Nilesh, and everyone here on this platform here for making it a great interactive session. Any closing
Yeah,
comment, Dr. Karun?
yeah. I just want to thank everybody, and I just want to give some closing remark that first and foremost, this is the first session, so I thank our speakers, Dr. Ashim and Dr. Nitesh, for giving the excellent input and excellent talk for this topic, which is non-union delayed union. Dr. Sanjiv and Dr. Abhishek, you are always excellent moderator. So thank you for your insight. Dr.
Thank you.
Daniel Moya, for giving your time. He's a co-chair for this web series. Giving your time, excellent, sir. Thank you. And Dr. Daniel Moya, again, I'm telling that he'll be speaker for our next webinar. Our secretaries for this course, Dr. Madhan is excellent. Dr. Satish is there. Dr. Dharshan is there. All three my our secretaries for this webinars were excellent. Special thanks to the OrthoTV team, is their brainchild, Dr. Ashok, Shyam, and Dr. Neeraj, Bijlani, for this excellent initiative. And again, next webinar will be on 20th of March. So stay tuned for this next webinar, which will be after next 1 month. And we will get to listen very new therapies of orthopedics, which we are not aware, because in India, very less spoken or done for all clinicians. That is shockwave therapies in orthopedics. So till then, stay tuned. Anybody wants to add any closing remark, please add. Otherwise, we will close this webinar for today.
Thank you, Dr. Jain, for a wonderful webinar. And we also learn a lot from this webinar. So thank you very much and good night to everyone.
Thank
Hi
you.
everyone. I think this was a great initiative to begin with. I'm so happy to see all of you coming together and talking about this a very difficult topic, especially for surgeons in India. So it's
This
great
is
to see
going to
insights
be
from
difficult
Madhan,
forever,
from
sir,
Karun.
but we are trying to make something best out of what we can do. This is a ever challenging topic in orthopedics.
Absolutely.
See, sir,
There's,
wherever we go in conferences, the maximum number of questions and maximum number of discussion is on orthobiologics, wherever we have a talk. So I think it's an
absolutely.
upcoming branch. And just to give stats to the audience, it is expected that in 2030, this is a stats by USA, that the orthobiological market will beat the market of plastic, trauma, and scopic altogether. So this is
Yeah.
just a statistic. So biologics is coming in a big way in orthopedics. They are very much in onco, but they are coming in orthopedics in a big way. So thank you, Dr. Ashok Shyam, for starting this lovely initiative.
Thanks a lot to all of you.
Thank you.
Thank you.
So
Bye-bye.
very
Good night.
thank you.
Thank you. Okay, guys.
Thank you.
Thank you, sir.
Take care.
Bye bye.
Take care. Bye.